Good evening, everybody. Welcome to the Prostate Forum of Orange County, California. Tonight, we are delighted to welcome Dr. Pooya Banapour to our stage for his very first presentation with us. He is a member of the West Coast Urology Group in Downey, California, and he is going to present to us the use of the Decipher Genomic Classifier in newly diagnosed prostate cancer and how it can help with individualized therapies, personalized therapies, and precision medicine.
Before introducing our speaker, a quick word about the Prostate Forum of Orange County. The forum is a group of men who themselves are dealing with prostate cancer and who want to support anyone else who is dealing with the disease. We do this by offering information, education and hope through our website, prostateforum.org, and through monthly support group meetings and presentations by experts. There are 2 online support meetings each month. The first, mainly for those newly diagnosed with prostate cancer, meets on the 2nd Tuesday of every month, and another meets on the 4th Tuesday of each month, mostly focused on advanced and recurrent prostate cancer. Both meetings are free and open to anyone affected by prostate cancer. In addition to these support groups, we also offer on most months talks by experts in the diagnosis and treatment of prostate cancer, just like tonight's presentation. Topics from these experts range from diagnosis to active surveillance to radiation, surgery, side effects, genetics, and other medical advances. You can learn about upcoming presentations at prostateforum.org/speakers or view previous presentations at prostateforum.org/presentations or on our YouTube channel at youtube.com/@prostateforumoc. To take advantage of these resources, we encourage you to sign up to receive announcements of meetings, presentations, and newsletters. And when you're ready, please consider helping us help others who are dealing with cancer. We're all volunteers, and we invite you to volunteer some of your time and expertise with organization, coordination, marketing, website maintenance, whatever you can. Whatever you can give will really help. And even though our volunteers are not paid, our expenses are very real. Your donations will help us to continue providing education, information, and hope to men with prostate cancer and their families and friends. With that, let's turn to tonight's speaker.
About Dr. Banapour, he's a board-certified urological oncologist with West Coast Division of Unio Healthcare, UNIO. I hope I'm pronouncing that right. He is an expert with cutting-edge and innovative therapies in the surgical and medical treatment of advanced urologic cancers, not just prostate cancer. And Dr. Banapour also trained in reconstructive urology and female urology and has worked extensively in building robotic and minimally invasive surgery programs. I know you want to ask questions and you want to learn more about how genomics can help you. So I will stop talking and turn this over to the doctor.
Thank you so much for that introduction. It makes me feel very special. Thank you guys for having me. I wanted to just first off say that, this is a really beautiful organization that you guys have built. When I was in training, prostate cancer forums and support groups were few and far between. So I became a little bit curious about the Prostate Forum of Orange County and did some reading about it, and I'm really, impressed by what has been created and the following it has. So really kudos to you for creating this organization and bringing men together, men and women together in understanding prostate cancer. Because there is a lot with prostate cancer, and it can be anxiety provoking, nerve-wracking, as I'm sure you can attest to. So it's a wonderful thing that you've created, and it's really an honor to be a part of it and to get to speak. This will be very informal. A lot of this presentation is kind of geared toward more medical professionals. If it gets too technical, obviously, please pause me and ask any questions. Hopefully this becomes of value to you and helps answer some unclear aspects of prostate cancer and gives people an introduction to genomics and how it can be useful. So let's see here. So a little bit about me. I'm a urologic oncologist. I'm part of a very busy community practice with 4 other urologists, as well as some advanced care providers. Within my organization, I'm the main urologic oncologist. So, I deal with a lot of advanced prostate cancer, both in the localized setting as well as in the metastatic or advanced prostate cancer setting when it's gone outside of the prostate. I work with the rest of our staff, with physician's assistants, with our medical assistants and whatnot to really try to create an A to Z experience for prostate cancer. I'm mainly at the Downey office, but I do also spend time at Los Alamitos, where I see a fair amount of general urology as well. I wanted to kind of quickly discuss just genomics in a nutshell and what it can offer. The main way I would kind of introduce genomics in the realm of prostate cancer is that the phrase "there are 2 sides to every story" kind of gives an indication of how useful genomics can be in prostate cancer risk stratification. Because us as physicians, we have a lot of substantive information, objective information that we can use to guide prostate cancer treatment. Mainly what many of you are probably familiar with: clinical pathologic information, PSAs, imaging results, digital rectal exam results, what have you. But genomics is an area of medicine within oncology that has really given physicians, patients, practitioners a little bit of an edge, a little bit more tools in the armamentarium to help guide prostate cancer management. And I always tell patients that although prostate cancer, nobody receives prostate cancer as a point in their life where it's something to look forward to or to deal with or to get treated. But if anyone were to live with prostate cancer, the time to live with prostate cancer would be now, just because there are so many treatment options available. There are so many tools available, and genomics is one of them. So we'll get into all of that. And genomics, the reason why it's useful is because it helps us with determining the plan. There's a lot of anxiety, a lot of very difficult decision-making associated with whether to do active surveillance or monitor your prostate cancer, whether to have surgery, whether to have targeted therapy, focal therapy, a radical prostatectomy, radiation, ADT, androgen deprivation therapy. So it can be extremely confusing, very anxiety-provoking, but genomics is another tool that helps us help patients and help patients better make decisions. So we'll talk about all that. So the Decipher test is a very useful tool that uses genomics, and we'll explain why it's so useful, and gives clinicians various more objective information to help really create the best decision possible for an individual. And as you're aware, prostate cancer is extremely personalized. So genomics really defines that core tenet about prostate cancer treatment, is that it's extremely personalized. A few prostate cancer statistics. So in 2023, the American Cancer Society is estimating that prostate cancer new cases, the incidence would be around almost 300,000, about 288,000 cases. And a fair amount of those individuals will pass from prostate cancer. So although it is not the most lethal cancer out there, it is certainly a very prevalent type of malignancy that men have to deal with. And anywhere from 1 in 6 to 1 in 5 men have to deal with prostate cancer. And I always explain to patients that it's more of a condition because of the array of treatments and options that are available. It's more of a new chapter that patients or people are starting in their lives. And hopefully with tools like genomics, we can better assist the treatment and decision-making. Prostate cancer tumors harbor a spectrum of metastatic risk. So what does that mean? What this basically means is there is a lot of variation or heterogeneity in terms of how aggressive prostate cancer can be. Even with having the same clinical pathologic features, so in other words, having the same PSA or having the same Gleason score or number of cores with prostate cancer, 2 prostate cancers in 2 individuals may behave very differently. Us as clinicians, we do use tools such as the PSA, the biopsy results, digital rectal exams in order to expect an idea of how a prostate cancer will behave. But these features are not alone enough. We know that because we see that there are Gleason 6 or low-risk prostate cancers that can behave very aggressively. On the contrary, there are also Gleason 7 and 8 prostate cancers that can sometimes have an even lower metastatic potential. Some unfavorable intermediate risk prostate cancers can have lower metastatic potential. So whatever tools or resources we can use to help answer that question will be very valuable in prostate cancer treatment. So to the left of the slide, this is just saying that there are features of prostate cancer that tend to be more higher risk features, and there are features that tend to be lower risk features. We're all probably aware the higher the PSA, the higher risk the prostate cancer can be. But we also know that PSA isn't specific to prostate cancer. It's specific to the prostate. So it's not always the most specific indicator of aggressive disease. Excuse me. Gleason score, same thing. So a Gleason 3+4 can behave very aggressively, or it can behave very indolently. Number of cores, and we'll see later, can be very influential in terms of cancer risk, or number of cores can be not as impactful as a factor. So although clinical pathologic features are extremely useful, they are also limited in terms of capturing the whole picture of prostate cancer. Again, that phrase, there are 2 sides to every story. There's the clinical pathologic side, and then there's the genomic side, which we unfortunately didn't have access to years ago. This is relatively new and extremely useful. Some of the other indicators that we can see to the right here, NCCN scores, CAPRA scores, STAR-CAP scores. So these are validated clinical pathologic risk assessment tools that are used to predict metastatic risk. But at the end of the day, these clinical variables and models can misrepresent the patient's risk for a significant portion of the time. So if we can access something that can give us a little bit more information about how aggressive or how not aggressive a prostate cancer can be, then it'll be very useful. So what does genomics mean and what can it do? So genomics gives us an idea about the underlying tumor biology at a molecular level, okay? And it's individualized, it's personalized for each patient. It doesn't rely on factors such as the PSA or the rectal exam. It's actually relying on molecular factors that are looking at the disease from a different perspective that can help diagnosis and management. And in addition, it gives you a more accurate stratification of prostate cancer and gives you an idea about metastatic risk. So it's extremely useful clinically. Decipher was originally developed to predict metastasis, right? So the intention was we're developing this tool in order to tell our patients some information about how aggressive their prostate cancer will be. What is the likelihood that it's going to go elsewhere? Because that's really what's going to affect somebody's life. Is it going to go to the bones? Is it going to go to the lymph nodes? Is it going to stay localized? That bit of information is extremely useful when making very delicate treatment decisions of active surveillance or radiation or surgery. These sometimes are the most important decisions men make in their life about what treatment they get or don't get. So having all of these tools, and I really want to hammer this home, but having all of these tools available is absolutely integral. So the way Decipher was developed is that if you think about it, a lot of prostate cancer, huge registry of prostate cancer patients was put together, and their genetic makeup was looked at. And they went backwards and kind of looked at the patients that got metastases and looked at their genetic makeup, what's in their DNA, what genes are actually expressed, turned on and turned off in the people that end up having metastases, and vice versa. What genes are turned on and off in patients that don't have metastasis. And using that information, a transcriptome microarray, or it's just a fancy way of saying that a genetic makeup was created of which genes are most relevant to prostate cancer, aggressive prostate cancer. And using that information, a risk assessment tool was developed. And this is the bar you see to the right of the screen. But this risk assessment tool helps clinicians and patients decide how to manage their disease, and it's extremely useful. The two settings in which Decipher is used is in the post-biopsy setting, so after your biopsy for prostate cancer. What the clinician or your urologist does is on their biopsy paperwork, when they sent it to get a pathologic analysis, they in turn send the biopsy specimen for Decipher testing. So it's done in that setting. It's also done in the post-radical prostatectomy setting. So in individuals who opt for radical prostatectomy surgery to have the prostate removed, clinicians can opt for Decipher testing. And in response to that, clinicians can get a printout, which we'll go over momentarily, that offers a lot of valuable information about the behavior of the cancer. This slide just basically shows that it's well covered. So we're living in an age and time where genomics, and specifically Decipher, is very well validated by level 1 evidence. So it's covered as far as most commercial insurances, as well as Medicare is concerned, and also is presented in the guidelines. So this is validated, clinically proven information that assists with management of prostate cancer. So this is backed by lots of information and data from large cancer registries and large academic centers as a validated tool. So there are various different modalities in which genomics can be taken advantage of by clinicians in order to help with prostate cancer risk assessment. So a few of those include Decipher, which is the topic of discussion today, Prolaris, which is another prostate cancer genomics test, as well as Oncotype DX. All of them kind of vary in terms of exactly what they offer. There are some important differences. Many of the other tests that are available include those clinical pathologic features that we discussed, things like PSA, physical exam, Gleason score. The Decipher test is really the only genomic tool or molecular tool that relies 100% on the tumor biology. So in other words, it's really taking all of the specific genomic and molecular information in order to give you a separate risk assessment tool to evaluate an individual's prostate cancer. It's not relying on those clinical pathologic features that we talked about. In addition, it's one of the more comprehensive genomic tools by virtue of the fact that it's evaluating multiple biologic pathways. So in other words, multiple genes, the most actually, that look at prostate cancer behavior. So if you think about it, it actually gives you the most comprehensive information out of all of the genomic classifiers that are available in order to predict a score and guide prostate cancer management. Decipher evaluates 7 biological pathways, again, not impacted by PSA, Gleason score, MRI findings, whereas many of the other tests do include some of the already known information that your urologist already knows. This slide just discusses that each test has different features, and these features determine its clinical utility or use. Prolaris evaluates one cell cycle gene, essentially. Oncotype DX looks at a total of 12 genes that look at 4 different pathways. Very useful tool. But then we come to Decipher, which includes 22 genes from various different pathways, 7 actually, that really get a full picture of prostate cancer, not just genes that are involved in invasion and metastasis, but genes that are involved in androgen signaling, which is how prostate cancer behaves, genes involved in cell metabolism, angiogenesis, or the growth of blood vessels, which is crucial to prostate cancer growth, and prostate cancer growth and differentiation, cell death, immune activity, and response. So what this means is it creates a snapshot using these genes that are involved in these integral processes to give you a risk assessment, to give you a number, actually more than that, give you a clinical picture in order to make the best decision for your disease, as well as from a clinician's perspective for your patients. This slide discusses the different tests that are available and whether they are predictive or prognostic tools, and the level of evidence that they have as being genomic tests useful for prostate cancer. So this is just a fancy way that doctors kind of communicate with each other when we want to discuss how validated or how impactful this scientific data or evidence is. So whenever we talk amongst physicians, we really uphold level 1 evidence as really the holy grail in terms of validity of scientific data. And Decipher is the only test that has actual level 1 evidence for being validated as a genomic tool. And this is based on multiple different clinical studies. This chart shows the number of total publications as of, I believe, 2021, since 2020 in Decipher, and this number is growing. If you take that consolidated amount of studies, it includes over 109,000 patients that are evaluated and their genetic makeups that are evaluated to produce this score. So there's a lot of data that's being harvested in order to utilize this tool for prostate cancer risk assessment. So it's backed by a ton of science and a ton of validated data. Over here, we just see that when we are using clinical features to predict behavior of prostate cancer, we tend to have a very limited picture in terms of how useful it is at predicting aggressive disease. So in essence, all we really need to know when we see this is the closer this number is to 1, the better it is at predicting aggressiveness of prostate cancer or risk of metastasis. So if we rely on PSA, rectal exam, Gleason score alone, we do get a good picture of how the tumor behaves, but not the complete picture. In turn, if we rely on Decipher alone, same thing. We do get a good idea of how the tumor behaves, but we don't get a full clinical picture. But when we add the two together, we certainly don't get the complete picture, but we get a much better idea of how the tumor behaves. So this slide just goes on to show that you get almost a synergistic effect from having both of these tools available. And this is what the report looks like. So it looks a little bit complicated, but up above, you see just some information about the patient, when the test was ordered, whatnot, who the physician ordering was. And then you see some clinical features, which is at the second row over here. What clinical stage the patient is at, the most recent PSA, the Gleason score. And then below, you see this prediction of Decipher score to the left, and you see this bar graph from 0 to 1, which indicates, based on the color and the location, the level of how aggressive the prostate cancer is, as well as the risk of metastasis. So the score is between 0 and 1. I'll kind of talk to you about how I use and how I interpret it. But suffice it to say that the numbers correlate to either low, intermediate, or high risk. And based on where a patient lands in terms of low, intermediate, and high risk, clinicians are able to guide patients into making the best decision. So one component of this printout of the sample report is the actual Decipher score. Again, independent of all of the clinical features and determined by tumor biology alone. And then to the right, you get an interpretation of what's going on. So based on the Decipher score with standard therapy, you get metastasis risk. So you get a number, you get a percentage actually, predicting your 5-year and 10-year risk of metastasis based on the unique expression or non-expression of those genes, or that molecular makeup. Again, you're not able to get this with a PSA or a rectal exam, because this test solely relies on genomics and the molecular makeup, which is individual to a person. You also get a number which predicts adverse pathology at prostatectomy. So this is extremely useful for patients who have had their biopsies and are considering definitive therapy versus active surveillance, things such as prostatectomy or radiation. And then finally, you get a clinical summary interpreting the individual score relative to what's known about patients with the same genetic makeup. So it'll kind of give a guidance statement. These patients may benefit from treatment intensification with multimodal therapy. So if a clinician is deciding whether to do surgery alone or radiation alone, having this genomic tool, specifically having a patient who gets a Decipher high risk, may sway a patient and their urologist to seek additional therapies such as radiation or androgen deprivation therapy, so multimodal therapy. And then on the second page of the report, you get this very nice graph explaining where this specific patient lies on the risk of metastasis through analysis of large volumes of data with similar makeups of genes. So for this specific patient, their risk of 10-year metastasis compared to over 6,000 patients with similar clinical features is about 6.5%. And really what's important and unique about this is that it's tailored specifically to the patient. So Patient A, who might have the same clinical and pathologic makeup as patient B, may have a completely different Decipher report. And that's what becomes extremely integral with prostate cancer treatment. Okay, so I'll talk a little bit. I'll try not to go too deep into the data, but I'll talk a little bit about why Decipher, how Decipher can be useful in the biopsy setting, as well as in the prostatectomy setting. So this slide just mentions that, or just is describing the fact that Decipher testing is now mentioned in the NCCN guidelines. So multivariable models such as gene expression classifiers, namely genomic markers or biomarkers such as Decipher, are very useful for risk stratification. Specifically in scenarios with low, favorable, intermediate, unfavorable, intermediate risk disease, they can be extremely useful in guiding treatment decisions. And then when determining candidacy for active surveillance, we know that patients with higher genomic risk scores, so individuals that are in the red area in Decipher, would probably not do well with active surveillance. That's kind of what we're getting at. If we kind of get a clinical picture where we're kind of deciding between active surveillance and definitive treatment, and we have information from genomic testing that this tumor may actually behave more aggressively than predicted, then we may want to redirect our patients and have them have definitive treatment rather than surveillance, because we know that based on the score and based on their genetic makeup, it's probably going to behave a little bit more aggressively. So we'll talk about the post-biopsy setting a little bit as well. In terms of physician principles in the NCCN for active surveillance, we know that if an individual gets a higher genomic risk on their Decipher score for an NCCN low-risk patient, we know that it's probably not a good idea to keep the patient on active surveillance. It's probably in the best interest of the patient to encourage them to have some kind of treatment done, whether that be radiation or surgical intervention. And we also know that individuals who are kind of in that gray zone, the favorable intermediate risk category, who have a low genomic risk score, these individuals may actually benefit from active surveillance safely, as opposed to being encouraged to do definitive therapy. I won't spend too much time on this slide, but all this is saying is that tumor volume isn't associated with aggressive tumor biology in lower Gleason score disease, but it is in higher Gleason score disease. So the volume of tumors or percent positive cores in a biopsy is associated with more aggressive tumor biology for higher Gleason scores. So tumor volume, this is all it's saying is that tumor volume isn't as useful for active surveillance decisions in lower risk disease. So this is just some information and evidence supporting Decipher from the MUSIC registry, which is a very large prostate cancer registry out of Michigan. But suffice it to say that patients who were kept on active surveillance and ended up having low-risk disease on Decipher, their time to treatment was a lot longer than patients who had high-risk disease. Decipher low-risk men may stay on active surveillance a lot longer than high-risk men. So again, high risk, encourage therapy a lot faster, low risk with low Decipher score, safe to be on active surveillance. So this slide talks about who the ideal candidates for active surveillance are. And in general, they're men with low-risk disease, as well as Decipher low-risk scores. Decipher low men have a lower likelihood of having adverse pathology and are ideal candidates for active surveillance. So the lower your Decipher score, the negative predictive value is a lot higher. So in other words, the lower the Decipher score, the chances of having an indolent or lesser aggressive behaving cancer are much higher. And these are the scenarios where, excuse me, where Decipher and genomics becomes extremely useful, because you may have 3 clinical pictures like this with 3 completely different patients, all in kind of the gray zones of prostate cancer treatment. One individual with low risk disease, but a PSA of 9.2, aggressive findings on an MRI, but also non-aggressive findings in terms of Gleason score. You may have an individual who has a high PSA, aggressive MRI findings, low Gleason score, and then a third individual who may be a little bit older, PSA is a little bit lower, but has a higher Gleason score and lower volume of disease. So these are what we call the gray zones of prostate cancer. So, you know, these patients can go either way based on if we're relying just on clinical pathologic features. One could argue that active surveillance may be a better option for patient A. You could also argue that surgery may be a better option, or radiation. The measurements that we have of success are extremely different for each patient in terms of prostate cancer treatment. And genomics helps you have another tool so that you can make the right decision for your patient. So Decipher is also extremely useful in the post-biopsy setting in terms of deciding radiation therapy and the timing of androgen deprivation therapy, short versus long term. I won't spend too much time on this, but for patients that have more indolent disease clinico-pathologically, the patients that tend to have lower risk disease on their, or lower Decipher scores, tend to be better candidates for less aggressive treatment, and vice versa. Higher genomic scores, higher risk scores in patients with unfavorable intermediate risk disease would tend to necessitate more treatments, such as radiation or longer periods of androgen deprivation therapy. This is an analysis of Decipher in an intermediate risk randomized controlled trial. And again, this is just really hammering home the point that in patients with Decipher high-risk scores, many of them would tend to benefit from more intense therapy, whereas patients with lower risk disease who have a lower risk of metastasis are more safer with active surveillance or less, or I should say, less intensive therapy. Again, hammering home that point, lower risk disease may be spared androgen deprivation therapy. So if we're in that gray zone trying to decide whether to place the patient on androgen deprivation therapy, which is associated with many side effects and adverse events, then genomics can help us decide whether that's the right thing to do or not. So this is an analysis of Decipher in 3 randomized controlled trials. Decipher low-risk men had good outcomes with standard of care, whereas Decipher high-risk men may need more treatment. And we see that the higher risk patients have a higher risk of metastasis as the years go on. Again, we get to that kind of gray zone where we have patients with similar clinical pathologic makeups, but can benefit or can really go either way in terms of their treatment. So Decipher can be very useful in determining the aggressiveness of the cancer and determining what the next step is. So some of the key takeaways that I wanted to talk about that we have talked about is that Decipher is extremely helpful for treatment decisions in different clinical scenarios, in the post-biopsy setting as well as in the post-radical prostatectomy setting, just because it gives you a completely different perspective than what is traditionally obtained from our diagnostic tools. It gives you that genetic makeup. It gives you an individualized and personalized perspective of how their prostate cancer is behaving and can guide treatment decisions. It's backed by clinical evidence and is the most validated genomic test in prostate cancer. And it's being used as an integral biomarker in phase 3 randomized controlled trials. And lastly, one thing that I personally believe in, and I think is going to be the future of prostate cancer therapy and already is happening, is future treatments are going to be based on genomic makeups, which are personalized. So advanced therapies, immunotherapies, various prostate cancer treatments are going to incorporate tools such as these to allow for more individualized treatment in order to get better outcomes. So an extremely useful tool. I try to offer it to really all of my patients who undergo biopsy, and especially to patients in those gray zones of prostate cancer, those low-risk patients that are, we as clinicians as well as patients are kind of on the fence about in terms of treatment, or those favorable intermediate risk patients where we're deciding between intense therapy and more indolent therapy. So an extremely useful tool, and hopefully something that you'll understand the importance of after this presentation. But that's basically it. I hope this was very useful for you, and I'm happy to answer any questions or discuss any other topics you'd like to go into.
Doctor, thank you. That was an amazing presentation. We do encourage our folks in our support groups to go out and get genomic testing. We've got a bunch of questions for you, and I think we'll come back to that issue that we do encourage that at Prostate Forum of Orange County. Let's start out with Ira's question. Why is Decipher preferred over Oncotype and Polaris for clinical trials?
Yeah, so great question. So first of all, I'd like to say genomics in general is something that is recommended. So if the question is getting any genomic test versus no genomic test, you should get a genomic test. So the difference between Decipher, Oncotype, Polaris, we're getting down to a lot of detail in terms of what can be offered clinically. But why Decipher is used for clinical trials stems from the fact that oftentimes when companies have a product that is more comprehensive or capturing a lot more information in terms of genetic makeup or molecular makeup, then they tend to obtain a lot of the market share and as well as support from the scientific community. So I think one of the reasons why Decipher has been involved in so many clinical trials is obviously the strength of the company, but also the scientific backing. Key opinion leaders in medical oncology, radiation oncology, as well as urologic oncology and urology have backed Decipher because it has been a very comprehensive risk assessment tool. So it's due to a variety of reasons, but mainly because it's extremely comprehensive and backed by good initial data in terms of its outcomes.
Neil?
Yes.
Hi, Dr. Banapour. This is Dr. Metzger. I appreciate your comments. Excellent talk. Could you discuss the difference between the biomarkers and BRCA1 and 2 ATM type of testing?
Yeah, sure. So I'm happy to kind of talk about that. So when we talk about BRCA ATM Check2, we're kind of entering the territory of germline and somatic testing. So that's a little bit different. So germline testing is another realm of genomic testing, which is used by clinicians in order more to guide treatment decisions, specifically with guiding therapies. So pardon me, I'm sorry, I'm getting a little bit of an echo, but there are various treatments that have been proven to be more effective in scenarios with more aggressive prostate cancer, where certain genetic defects are present, such as the ones you referred to, BRCA1, BRCA2, Check2, ATM, and what have you. But that's in the realm of germline testing, which can be a saliva or blood test, which clinicians use oftentimes in a more advanced setting, such as in a metastatic setting, to guide more advanced therapies. Typically, we're looking later down the line in prostate cancer when we're considering second, third, or even fourth line therapies for advanced prostate cancer or metastatic. This discussion is more for localized prostate cancer and how Decipher genomic testing can be useful in treatment decisions for local prostate cancer.
Thanks. That clears up that little bit of confusion. Appreciate your efforts tonight. Thank you.
Let me get
Sure.
one more question in for Dr. Metzger. What is your opinion of renaming Gleason 3+3 a non-cancer?
Is this for me or for Dr. Metzger?
It's actually from Dr. Metzger to you.
Oh, sure. Yeah. So the reason for that is a lot of the scientific community has understood through many years of compiling data about the behavior of low-risk prostate cancer is that it tends to be more indolent. So just like all things in medicine, I think that it's a gray zone. There is some evidence and actually substantial evidence that Gleason 6 disease tends to behave in an indolent fashion, but that's not always the case. And that's why we have genomics as a tool. It's not always that Gleason 6 behaves in a fashion that grows slowly or doesn't metastasize. You can talk to almost any urologist and they can anecdotally tell you about patients that had Gleason 6 disease and one or two of them or maybe a handful of them became metastatic. So the truth is, despite all the data we have about prostate cancer and its behavior, we still don't understand much about it. We have these tools. We're getting closer to understanding the full clinical picture, but we're still extremely limited. Our biopsies are limited. Our pathology reads are limited. I think there is some truth to the fact that Gleason 6 behaves a little bit more indolently, but it's a gray zone. I think it merits a discussion with a urologist as well as your physician or oncologist about how to treat Gleason 6 disease. But in general, there's no hard and fast rule. I think it's a good way to characterize or categorize prostate cancer, but certainly not black and white.
Very good. I think in the old days when we weren't doing targeted biopsies, we were just flat out missing the significant disease. And those are the ones that went on to develop issues, even with the PIRAD system and the PSMA scans. I think we're still missing some, but probably missing fewer of them.
Yeah, exactly. That's a great point. I think now with advanced imaging and genomics, we're able to capture more of what was previously characterized as Gleason 6 disease into more aggressive disease. So in other words, what we thought was Gleason 6 disease could actually be more advanced disease.
Again, excellent talk.
Thank you. Adrian has a question. Hi, Adrian. Welcome back. Is there a value to repeating the Decipher test for a second or more time during active surveillance? will the tumor biology change over time or as the tumor develops?
That's a really astute question. So excellent question. I can tell you've been paying attention. So the answer is yes, there is value to it. Again, no hard and fast rule, but in general, whenever there are features in the prostate cancer that change, it merits a discussion with your urologist about repeating a genomic test. So in other words, if PSA changes, if Gleason score changes, the inherent tumor biology and gene expression profile of a patient may change. And that's the beauty of genomic testing, is that it can be variable with time and with disease progression. So I always tell patients, if there is a significant change in the disease, whether it be clinical pathologic, or otherwise, maybe it's failing a current treatment like active surveillance, then it merits at least a discussion about repeating genomic testing.
Thank you.
Excellent. Ira has a two-part question. Does Decipher show each gene, such as a BRCA for patient viewing? And second part of that, does Decipher also do germline testing? And that's a term I've not heard before, germline testing.
Yeah, so the answer is no. It doesn't offer you a picture of the individual gene expression pattern, but it gives you a score as well as pictorial data about how an individual's genetic makeup stacks up, if you will, against large volumes of data and the inherent sequela or results of that in terms of clinical decision making. So I'm sorry, the second part of the question was?
Does Decipher also do germline testing? And that's not a term I've heard before, germline testing.
Oh, sure.
Maybe we could clear up what that is.
Yeah, sure. So when we think about advanced prostate cancer testing, there are generally two categories. There's germline testing and what's called somatic testing. Germline testing tests cells that are present in the body. So this can easily be assessed by a saliva test or a blood test, whereas somatic tumor testing tests the behavior of the individual prostate cancer cell. So for the purposes of this discussion, germline testing can be a saliva or a blood test that will give your clinician exactly what you asked about, results about their specific genes that are turned on or off. And the type of germline test that you get, there are various types of vendors that do germline testing, can give you a lot of information about the clinical picture, about how the prostate cancer is behaving. Now, there is no consensus about when germline testing should be done, but in general, when prostate cancer becomes advanced, fails multiple therapies, when there's certain family risk factors, certain aggressive tumor biologies, it's generally recommended and is included in the NCCN in that scenario. But for the purposes of localized non-aggressive prostate cancer, it's generally not routinely done. But as far as germline testing is concerned, there are various companies that do it. There are even proprietary kits that are available that can be purchased and done at home and sent to the company, and that printout with the different genes that are turned on and off can come back and be used by a clinician or a patient for decision making. But for the purposes of localized prostate cancer, it's generally routinely not done.
Okay. Bert wants to know, what does tumor biology signatures mean?
Yeah, so think of it as a prostate cancer fingerprint, right? So although patient A might have a PSA of 6, patient B might have a PSA of 6, they may have the same Gleason score, their genetic fingerprint is different, just like their actual fingerprints are different. So that term refers to what their individual and personal genetic makeup is, or gene expression and non-expression pattern is, or mutation pattern is relative to one another. So just like you and I have different fingerprints, we have different tumor biology makeups as well.
Excellent. I want to bring Dr. Metzger back for a question about biomarkers versus BRCA1 and 2.
Sure. So is the question what are biomarkers versus BRCA1 and 2?
I think we covered that.
That's what the question.
Okay. Yeah, in general, I mean, BRCA1 and BRCA2 are actual genes, whereas biomarkers are more of an umbrella term that refer to anything in the molecular makeup that can give you information about cancer or the behavior of the cancer. But suffice it to say that BRCA1 and 2 are just more specific indicators of tumor biology, or specific genes that can be turned on or off.
Okay. Samson wants to know if a Decipher score of 0.6 considered intermediate or high risk.
Yeah, that's an excellent question. Generally, it's in the intermediate risk category. What can happen is, since large volumes of information are used to interpret that score, it's always wise to have a discussion with your urologist about what that score is and how to interpret it. So that score of 0.6 may have very different, may cause a very different discussion in a patient with less aggressive clinical features versus a discussion with a patient who has more aggressive clinical features. So it should it's one piece of information that should be used in addition to a whole clinical picture for decision making. I will say that one of the more influential and impactful things about Decipher is when we get a high risk or a low risk score. This is more useful in terms of clinical decision making because it makes it a little bit more black and white in terms of the score. The intermediate risk patients or intermediate scores should be taken in the context of the other available information that your urologist or oncologist has.
Great. Jerome has a personalized question. He says his recent Decipher test result was 0.67. He's 71 years of age. He's clinical stage T2B with a PSA of 11.5 and a Gleason of 4.5. And he's hoping to put Decipher together with these other elements and make a decision about surgery or radiation.
Yeah, so I think you did an excellent job by discussing with your clinician to have a genomic score available. And really the answer is different for each person. One aspect of prostate cancer that I'm sure is discussed among the community, but we didn't get a chance to kind of discuss in this talk, is goals of care and goals of treatment. And that incorporates various aspects of treatment, which include sexual function, functional capabilities after treatment, things like stress incontinence risk, incontinence risk in general. So there's a lot more that affects clinical decision making than just the genomic score. But your genomic score should definitely merit a discussion with your urologist, as well as your radiation doctor in terms of deciding the best treatment for you. But it's really going to depend on the goals of care and the expectations that you have, and really your life and what kind of quality of life and what your expectations are after treatment. And that will really help decide the best treatment for you. I have several patients and have encountered several patients who have been in some situations that are very similar to yourself, but many would actually benefit from radiation instead of surgery, and others would benefit from surgery instead of radiation. A lot of components come into play, like age, expectation about, again, sexual function, functional capabilities before and after surgery, and urinary function. So all of these factors come into play. But I think you're in a good position in terms of availability of data and information, and certainly in a great position to have a very detailed discussion with your provider to decide on the best treatment for you.
And that's the kind of thing we talk about a lot is goals of care. And we talk about that a lot in our newly diagnosed support group and our Gleason 3+3 support group, and especially in our advanced support group is side effects and where you're going and how happy you're going to be with the result of one thing over another, and the latest treatments, which include MRI-guided SBRT, which is a game changer. Ira wants to know, at what point would you choose a more inclusive test such as Foundation 1 CDX?
You know, I'm not at liberty to kind of give you decisions about, you know, your specific scenario in this setting. But I think a discussion with your healthcare provider about the available kits and what they can offer, and you know, how useful they may be in terms of what kind of genes they assess, in terms of what your expectations and goals of care are, would really determine the answer to that question. So it really depends on the person, what their goals of care are, what information they want to actually acquire from the available kits or tests that are out there. And that really determines, you know, what the best choice is for them.
Could you briefly explain what the Foundation 1 CDX test is?
Yeah,
sorry,
so
sorry to interrupt, but I don't think I know what it is.
Oh, sure. So there are various of these germline tests that are available. Okay, some are saliva tests, some are blood tests, but essentially what they do is they take a piece of your DNA and they utilize the DNA either through your saliva or through blood, and are able to create a genetic makeup or genetic array in terms of what genes are possibly mutated, such as BRCA, CHEK2, A2M. There are various others. And each test or each company assesses different genes. And many of these genes are involved with cell cycle regulation. Many are involved with what we call recombination repair or mutation repair. So these genes have different functions in terms of how the cells behave. And the Foundation 1 test has a unique kind of assessment of which genes are expressed or which are mutated. So it can be extremely useful when deciding treatment for more advanced prostate cancer, when assessment of BRCA stage or BRCA mutation is more useful in terms of treatment. So this is typically, in my practice, more second, third, or even fourth line in terms of prostate cancer treatment, more for advanced prostate cancer.
Thank you for just explaining it.
Sure.
Brian has a question. What advances do you see in this area of genomics? Maybe a larger pool of genes for more detailed fingerprint? Maybe smaller, more refined sets?
Yeah, great question. I think we're going to get to a time where we're going to leverage the power of artificial intelligence and just obtain larger volumes of data. And larger volumes of data will be able to tell us and pinpoint exactly what types of mutations are behaving or causing more aggressive tumor behavior, and what types of gene expressions that are turned down that are responsible for less aggressive behavior. But I think we're going to get to a time where we're going to have an even more refined risk assessment tool. It may be, you know, something like the Decipher test, but backed by much more data and much more analysis of genes and analysis of the behavior of genes over longer term. But I think we're going to get to a time where we're harvesting the power of AI to get more detailed and more informative tests that can even give us more information, not just about metastatic risk, but about risk of metastasis to specific organs or bone. So we're entering a very interesting time where a lot of information is going to be available and a lot of more personalized or individualized care will be available.
Keith wants to know, how long does it take to get results of a genomic test, and how would I go about initiating it? I am post-biopsy with a tentative decision for surgery. My surgeon has mentioned post-surgery genomic testing, but not, let's see if that's but not before
Not
that.
pre. I see.
Not pre.
Yeah. So, you know, Shihab and I have created a really good system, so our turnaround times are pretty short. I would say, in my experience, Decipher has been one of the fastest, usually by 2 weeks. So within 1 to 2 weeks, I'll get the results back. I think in terms, so one thing that's very useful is that genomic testing can be done retroactively too. So even though you've had your biopsy, it is possible to still get a Decipher test done. So my advice to you is you talk to your urologist and let them know if it would be, if you know their infrastructure would be capable of running a genomic test, specifically a Decipher from your biopsy, and getting some information about that to assist with your decision making. So that's what I would suggest.
Outstanding. I don't see more questions in the chat. Does anybody have anything else to ask Dr. Banapour? Okay, there'll still be time. And before we say goodnight, I want to thank you, Doctor, very much, and thank your staff for helping us with this presentation. It was outstanding. And please keep us posted as anything new comes up. Talk with Dr. Metzger and let him know, hey, something new comes up, and I know your people are going to want to know about it. Bob Morris came in with use and post DURGERA /. That's not a term I've heard.
Surgery.
Oh, surgery. Okay.
Typing.
Okay. So you want to know post-surgery, how would Decipher help you?
Right.
Yeah, that's an excellent question. So post-surgery, obviously we have pathologic data available. So based on the pathology results, we'll know the volume, the location of the cancer. We know the Gleason score. And if lymph nodes were obtained during surgery, we know the lymph node status too. But oftentimes, this still creates a gray zone in terms of what we do next. Many clinicians, including myself, will follow PSA results after surgery to guide treatment decisions. But if we utilize and harvest the power of genomics, we may have answers to that even quicker. So in the post-biopsy setting, in the post-radical prostatectomy setting, genomics can give your clinician a better idea of how aggressive this cancer will be in terms of going to other organs or even recurring. And why is that useful? That's useful because he'll encourage you to do radiation or be on androgen deprivation therapy a little bit earlier on, depending, again, on goals of care. So if an individual's goal is to be cured as long as possible and not have to deal with this, which I'm sure most men are, your clinician may want to have you see a radiation oncologist and discuss radiation immediately after surgery, again, depending on various factors. Or your clinician may want to start you on androgen deprivation therapy to bring your testosterone down a little earlier on. Or your clinician may just want to check your PSAs a little with more frequency, maybe every 3 months instead of every 6 months. So it's just another tool that will help us make the best decision for each patient. And prostate cancer is, again, despite what we've overcome and all the information we have, it's still a gray zone. there's still so much that we don't know about it. So having more tools, more information available will help clinicians and patients make the best decision.
Well, thank you. A couple of little bits of housekeeping in the remaining 15 minutes. Number one, I'm going to talk to our YouTube audience of the future. If you're now watching this weeks to even months after we've done this, you're missing out on a great deal of Prostate Forum of Orange County. Be sure to get to our website, prostateforum.org, and sign up for our newsletters, sign up for our meeting announcements, our support group announcements, and check us out for what's already online on newsletters, videos that go back 10 years or more. The second bit of business is that everybody that in this organization, one way or another, is a prostate warrior. You can work from home and you can help us do so much of the work we need done that really isn't all that difficult. In particular, we're looking for marketing people. We're looking for people who can help us with our website. You can email us at prostateforumoc@gmail.com. That's prostateforum, O as in ocean, C as in Charles, @gmail.com. And give us a little bit about your background, your contact information, email, phone number, and let's get together and let's expand the people who have helped make this organization so great over the last 30 years. This will be up on the website for you attending live. In a few days, you'll be able to watch it again. I'm going to once again make a call to see if anybody wants to ask questions before saying good night to Dr. Banapour and his staff. Well, with that, Doctor, I thank you and your staff, and we look forward to working with you in the future.
It's my pleasure. It was nice talking to everybody, and I look forward to talking to you guys again in the future too, and keeping you updated.
Thank you so much. Everybody have a great night.
Good night.